And let me just start sharing my screen. RX events, you will have to allow me to share the screen. Yeah. So I hope my screen is visible and I'm audible.
Yes, sir.
Yes. Go ahead, Dr. Unni.
So I'm going to talk about hypothyroidism and diabetes, especially thyroid disease and diabetes. What are the connections? So let me begin by showing you this paper we published many years back in 2013, which looked at how common is hypothyroidism and other thyroid disorders. You can see that the prevalence of undetected overt hypothyroidism is about 3.47%. The prevalence of subclinical hypothyroidism is 8%. Hyperthyroidism is 0.67%. But if you see, the prevalence of diabetes is 16.6%. And this is a study done in 8 cities of India. And why I'm showing you is because this data shows the thyroid disorders carried out in the same population. So thyroid function tests and diabetes diagnosis was carried out in the same population. So hypothyroidism shares many commonalities with the metabolic syndrome and type 2 diabetes. You have obesity, dyslipidemia, insulin resistance, hypertension, NAFLD, and severe risk in hypothyroidism. All these features are also seen in type 2 diabetes and the metabolic syndrome. So there is an overlap of the symptoms. This is a busy slide, but I just want you to focus on the lower end of these slides because this picture shows you what thyroid dysfunction does to blood glucose levels. Hyperthyroidism results in apoptosis of insulin-producing cells of the pancreas. This results in hyperglycemia. The insulin clearance is increased, and that therefore there is a lack of insulin and there is hyperglycemia, and maybe even diabetic ketoacidosis can occur. Very simply put, the insulin or diabetes medication requirement can increase in diabetes patients if they have hyperthyroidism. If you look at hypothyroidism, there is a reduced insulin clearance, which means insulin levels go up, which means exogenous insulin requirement can go down in diabetes patients. And there is a risk of hypoglycemia in diabetes people who have hypothyroidism. So you need to decrease the insulin dose in diabetes people when you have hypothyroidism. But once you replace with thyroxine, you will have to increase the insulin dose. So just to tell you, to summarize, hyperthyroidism has a tendency to hyperglycemia and hypothyroidism has a tendency to hypoglycemia. So many people have suggested that type 2 diabetes is associated with an increased risk of thyroid nodules. But is there an increased risk of thyroid cancer? So this paper was done on almost 147,934 women. They were free of cancer at baseline and were followed up prospectively. The follow-up period was 15.9 years, and they found 391 incident thyroid cancers. But the authors found no significant association between thyroid cancer and diabetes, and there was no significant association between thyroid cancer and diabetes treatment or with the duration of diabetes. So there is no evidence to say that thyroid cancer is associated with diabetes. Now, in a person with diabetes, how often should thyroid function test be done? So this depends on the type of diabetes. In type 1 diabetes, TSH and anti-TPO antibodies should be done at baseline and annually. If a type 1 diabetes has got a goiter or if GAD65 antibody is positive, if there are growth issues, pubertal issues, fluctuating sugars, then you may need to do the thyroid functions more frequently. About 25 to 30% of type 1 diabetes subjects have autoimmune thyroid disease, and that is the reason you have to be more careful and do frequent thyroid function tests. In type 2 diabetes, thyroid function tests should be done at baseline. Routine repeated testing is not needed in type 2 diabetes, and there's no need for routine calcitonin tests in patients with type 2 diabetes who are on GLP-1 receptor agonist. So let's look at a case. A 54-year-old lady with a TSH of 14. She has a normal T4 and T3, BMI is 31. She is asymptomatic, HbA1c is 6.4% on metformin and sulfonylurea. There is dyslipidemia. So certainly such a patient would be an ideal patient for treatment with levothyroxine because this is subclinical hypothyroidism and the TPO is also should be done in this patient, but nevertheless, because of dyslipidemia, treatment with thyroxine is ideal in this subclinical hypothyroid patients. In fact, it's important to treat with thyroxine and then only give statin because giving statin first may increase the risk of muscular pains, etc. So we've already looked at simple problems like hypothyroidism and diabetes. Now let me look at some new ideas. There is some exciting basic science data on MODY genes and thyroid cancer, type 1 diabetes masking the diagnosis of thyroid disease, and insulin sensitizers. So let me talk about MODY, maturity onset diabetes of the young or monogenic diabetes. Now, there are many types of monogenic diabetes, but if you look at these two mutations in the hepatocyte nuclear factor 1 alpha and hepatocyte nuclear factor 1 beta, they are responsible for MODY type 3 and MODY type 5 respectively. If you look at HNF factor 1 beta, HNF factor 1 beta is a cause of MODY type 5, but it is also expressed in papillary cancer cell lines of certain types. And HNF1 alpha, which is responsible for MODY type 3, is the HNF1 alpha mRNA and protein have both been detected in anaplastic thyroid cancer cell lines. Now, there is no need to worry or panic about this because this is a very preliminary finding and is in the basic science domain. This just says that we should do more research on HNF1 alpha and HNF1 beta in the thyroid cancer cell line so that you can individualize molecular and targeted therapy for thyroid cancer. These are new ideas and they do not have any clinical relevance at present, but something exciting which researchers in the lab are working on, I thought I will share with you. So after this, I'm going to talk about type 1 diabetes masking the diagnosis of thyroid disease. So friends, let me show you a case. This is a 13-year-old lady with newly diagnosed type 1 diabetes. In this young girl, the HbA1c is 13.5, the random blood glucose is 456, the GAD antibody is positive. Note that the anti-TPO antibody is also positive. The TSH is low at 0.54 and free T4 is 0.78. I want you to note that this girl with type 1 diabetes, autoimmune type 1 diabetes, because GAD antibody is positive, has got autoimmune thyroid disease because TPO is positive. But because of the new onset hyperglycemia, this hyperglycemia can suppress the TSH and mask the diagnosis of type 1 diabetes. So in addition to type 1 diabetes, people having autoimmune thyroid disease and hypothyroidism, as I discussed, sometimes the diagnosis of type 1 diabetes may be masked. The diagnosis of hypothyroidism may be masked by type 1 diabetes. Why? Because in type 1 diabetes, there is hyperglycemia, weight loss, osmotic diuresis, and in hypothyroidism, there is weight gain. And this weight gain of hypothyroidism may be masked by the weight loss of recent onset type 1 diabetes. Second thing is, in hyperglycemia, severe hyperglycemia, there may be a defect in the T4 to T3 conversion. So you may have a low T3 and a not so low T4. The third is in type 1 diabetes, some authors have postulated that there is an unknown thyroid hormone binding inhibitor which may inhibit the deiodinase that converts T4 to T3. Finally, as I said, very severe hyperglycemia can suppress the hypothalamus, suppressing TRH, suppress the TSH, and also suppress the thyroid hormone, so all can be low as in this case. So coming back to this patient, of course, you would be managing the type 1 diabetes with insulin, but you should repeat the thyroid function test after giving insulin and normalizing the sugar to see if there is a latent unmasking of hypothyroidism, which is very important in young children, because if you don't correct hypothyroidism, it may have an impact on puberty, academic performance, height, etc. So this is the Bcct study. As you know, the Bcct study is the largest study on type 1 diabetes, showed that controlling glucose intensively with insulin reduced neuropathy, nephropathy, and retinopathy. But in this cohort of the DCCT, they took two groups, one with positive anti-TPO, other with negative anti-TPO. The x-axis shows the duration of diabetes. The y-axis shows the percentage of people who did not have hypothyroidism. So you can see that people with a negative TPO, a higher proportion did not have hypothyroidism, and patient with positive TPO, a lower proportion did not have hypothyroidism, which means that a higher proportion had hypothyroidism. So if you look at the normal adult population, the TPO antibodies double the risk of progression to hypothyroidism. But if you look at this DCCT cohort of type 1 diabetes, DCCT subjects who are TPO positive had a 17.9 times. So in the normal population, there is a twofold increase with anti-TPO, but in the type 1 diabetes population, there is a 17-fold increase in hypothyroidism with anti-TPO compared to anti-TPO negative people. And you can see that this was statistically significant, and hypothyroidism was more common in women. So just to show you that in type 1 diabetes, TPO is a very strong predictor of hypothyroidism. This is a small paper I published in 2006, which looked at TSH receptor antibodies in type 1 diabetes. And we found that some proportion, 18% of this very small study, had TSH receptor antibody positivity. Remember, TSH receptor antibody positivity does not mean hyperthyroidism. It can, if it's a blocking antibody, it means hypothyroidism. It's a stimulating antibody, it means hyperthyroidism. So it could predict both. And we saw that these antibodies did not overlap. They identified TPO and TRAB, identified distinct subsets of patients. Of course, this is a study which requires more research and a very small sample size. So not very important, but I thought I will discuss it. Finally, I come to my third topic, which is insulin, sensitizers, and hypothyroidism and thyroid. So this is a very important study, a retrospective study done in euthyroid diabetes patients. They were divided into two groups. 119 subjects who were never treated with metformin and levothyroxine, and the TSH was done. You can see the baseline and end of TSH was same. 203 subjects who were only given metformin at recruitment, and you can see that metformin reduced the TSH in these euthyroid subjects. This here, metformin reduced the TSH in that subject, and 71 subjects who were given, who were already taking thyroxine and were euthyroid, and metformin was added on. So in this group, on your extreme right, there was no metformin. In this group, there was metformin, and here there was metformin in a background of thyroxine. All were euthyroid. What you can see is that in this group, addition of metformin suppressed the TSH in these hypothyroid subjects taking levothyroxine. And this was statistically significant. So metformin has a tendency to suppress the TSH. So again, these authors did further analysis. They took the subjects and did a multiple regression analysis for TSH levels at 1 year of follow-up as a dependent variable, and they found that metformin was, again, in this multiple regression analysis, metformin significantly lowered TSH, and the authors said that metformin can reversibly suppress TSH, which means if you remove the metformin, TSH can go up. Metformin also reduces the TSH if the TSH levels are initially high, about 2.5 in hypothyroid people with diabetes. Now, why does metformin suppress the TSH? We really don't know, but there are some theories. Earlier, it was believed that metformin decreases the absorption of thyroxine. Now, people don't believe that theory. People believe that metformin acts on the brain, suppresses the hypothalamic TSH releasing hormone, that suppresses the pituitary TSH, and the suppression of pituitary TSH is because of a central action of metformin. There are some other studies that suggest that metformin increases the action of TSH via the IRS1 pathway. So metformin via the IRS1 pathway, because of the insulin sensitizing pathway, makes the TSH work better. So the body has to make less TSH. So these are some of the theories, but in practice, always remember that metformin can suppress the TSH a little bit, may not be clinically significant, but an important point to remember. Now, this is another study which described pioglitazone addition to patients with thyroid-associated orbitopathy. We know that Graves' hyperthyroidism affects the eye, and in this study, when type 2 diabetes subjects were given pioglitazone with Graves' disease, there was an exacerbation of thyroid-associated orbitopathy or Graves' orbitopathy. But when they withdrew the pioglitazone, the Graves' orbitopathy did not remit. Why does this happen? This happens because the expression of PPAR gamma is very high in the adipose tissue and connective tissue of the orbit. So therefore, if you give pioglitazone, that activates the PPAR gamma. That activation can stimulate functional TSH expression, and the TSH receptor antibody binds to the functional TSH receptor which is expressed in the orbit. So very simply put, the thyroid orbitopathy overexpresses PPAR gamma. Pioglitazone stimulates PPAR gamma. Stimulation of PPAR gamma worsens orbitopathy by expressing the TSH receptor. So that's a vicious cycle. And pioglitazone also induces the recruitment and differentiation of orbital fibroblasts into lipid-laden adipocytes. So when the fibroblasts in the eye convert into lipid-laden adipocytes, which are inflammatory and stimulate further adipogenesis, this may worsen the pathogenesis of thyroid-associated orbitopathy. So avoid pioglitazone in thyroid-associated orbitopathy. This is a case study. You can see this patient see the photograph before pioglitazone or thiazolidine was added. After thiazolidine was added, you can see that the TZD caused lid retraction, proptosis, and worsening of orbitopathy. And you can see the enlargement of the inferior rectus muscle demonstrating that. So important to avoid pioglitazone in Graves' disease, even if they have no orbitopathy, because orbitopathy, if there is mild, it can be worsened. And of course, avoid pioglitazone in thyroid-associated orbitopathy. Well, I've discussed some of the important clinical points of thyroid disease and diabetes, the connections. I've talked about the importance of diagnosing and treating hypothyroidism in people with diabetes, and that treatment is very important. I also talked about certain newer aspects such as insulin sensitizers and thyroid disease, metformin and thyroid disease, TZDs and thyroid disease, how type 1 diabetes may mask hypothyroidism, and the importance of diagnosing and treating hypothyroidism and other thyroid diseases in diabetes. Friends, it has been a pleasure discussing this topic with you, and thank you for listening to me.